Hello again, everyone. I have no idea if anyone has listened to the two previous webinars I've done, but if you have, welcome back. If this is the first time, I would refer you to the first and the second webinars because there's quite a bit of overlap between them, and they have been very much designed as a sequence. So today I will be referring to things fairly briefly that I talked about in a little more detail, particularly in the very first webinar 2 weeks ago. In many ways, this has been the most difficult of the three webinars for me to pull together. Self-regulation is a very complicated topic, and it involves many, many aspects of development. It's also been very largely overlooked and neglected in the field of deafblindness and complex multiple disability until fairly recently, I would say the last couple of years. It's impossible for me to talk about self-regulation without talking about executive function. And I can't talk about executive function without talking about sensory integration. I also can't talk about sensory integration without talking about the way our senses develop. And most importantly, I also have to talk about self-stimulation and about self-determination. So this webinar will touch on topics that I mentioned in the first two talks, and it will cover a lot of ground in a fairly short time. Because of that, as in the first two talks, rather than focus on specific strategies, I'm not aiming to say this is what you might want to do if you have this problem. I'm going to put more emphasis on sharing a particular view of children, which I hope will stimulate you to further study and discussion. And if the view I'm promoting is one you share, then I hope this will be a helpful reminder or maybe even a morale booster for you. If it's fairly new to you, then I hope you'll think about it seriously and see if you can perhaps amend the way you've always approached children and viewed children, whether you're assessing or programming and teaching. Once again, children with charge syndrome will feature in my talk because they provide a particularly useful field for study, and the difficulties that they have with self-regulation is now stimulating a growing body of research. Some of the handouts for this webinar are the fruit of this recent research work, and especially the papers by Nicholas and Hartshorn, and I think you have 4 or even 5 of them in the handouts. They obviously go into much greater depth and give many more practical examples than I can do in this talk today. Self-regulation is an incredibly important aspect of development, and I'm rather embarrassed when I say that in the field of complex disability, we haven't really focused on it too much. We've been very distracted by the whole area of language and communication. There's quite an emphasis on motor skills and movement and mobility. And then we get very quickly onto literacy and numeracy. And self-regulation has always tended to be ignored unless there's a problem. And then people start to be aware of the issue and start to ask for help. So this really today might be a fairly new experience for many of the people who will be listening. I've been asked, someone I know watched the first webinar that I did, listened to it, and contacted me and said, could I say a little bit about me? Apart from the fact I'm British, I've been in California for 18 years. and I've been a deaf-blind specialist teacher for most of my career, for 35 years, in fact. Will I say a little bit about me? So I'm going to begin with talking about my gurus, if you like. I have three main gurus, all of whom have passed away, unfortunately. The first is Lily Nielsen. Lily was a Danish teacher, and she created a philosophy and a practical approach to teaching, which she called active learning. And from Lily, I took these things. She was very hands-off. She felt very passionately that if children had complex disabilities, especially including sensory impairments, we tended to touch them, hold them, guide them, move them far too much. There was far too much physical direction, and that we should be much more hands-off than we had been historically. Her work has a very strong focus on the child's self-image and self-esteem, as well as on more traditional skill acquisition. She makes very clear statements about the importance of allowing time for learning and allowing time that's unique to the individual child. She pushes the idea, which is very close to my heart, of very close observation of the child. And I think the most important thing I got from Lily, the idea that if you change the environment around the child, you can change the child. You can change their functioning, you can change their behavior, and often you can teach through manipulating the environment rather than always teaching directly to the child or on the child. Lily also designed and produced all kinds of equipment to back up her approach. And two of those ideas, the little room and the resonance board, are particularly helpful. And I would suggest that you investigate if you're not familiar with the little room and the resonance board. There's all kinds of information about them on the internet. The little room is like a child-sized play box, if you like. And the resonance board is just a birchwood board, which is raised very slightly around the edges off the floor. And the child can stand on it, lay on it, sit on it. And any movement on the board resonates, it vibrates, and it amplifies sound. And I've used both those pieces of equipment with children from being young babies right up to being in their late teens, if appropriate. This is not baby equipment, which is a common misconception. There's no age appropriateness for either of those pieces of equipment. And you can use them for all kinds of purposes in your assessment and your teaching. My next guru, and my big guru really, is Jan van Dijk, who died at the beginning of this year. He was a Dutch psychologist and teacher of the deaf, and he was active in the deaf-blind field from the mid-60s until, still working, right up until he died a couple of months ago. He was the man who came up with the idea of following the child. The job of the teacher is not to get the child following them, but to follow the child. And the whole point of following the child is that it allows you to build a relationship so that one day the child will follow you because they want to, because they like you, because they know you, because they trust you. He also pushes the importance of careful, close, continuous observation of the child. The importance right at the beginning of identifying and using motivators, and they are the individual child's motivators, not our idea of what's a motivator. He also pushes the importance of getting the timing and the pacing right for the individual child, at the moment when you are with them and working with them. He tells us that we should credit all the child's behaviors with having meaning. He's a big, big proponent of teamwork, the need to respect and seek the opinions of others involved with the child and share and come to a consensus about what we're doing and what we're trying. Because of his training as a teacher of the deaf, he recommends that every interaction we have with the child should have the structure of a conversation or a dialogue, even if there's no actual language involved. If it's purely gestural, then we still need to maintain that turn-taking aspect that we have in conversation. He also talks a lot about the child's preferred modes of communication and the importance of building relationships. And he stresses all the time that relationships with these children have to be built. They have to be worked at, and the onus is on us to do that. And then my third guru is Jean Ayres. Jean Ayres was an American occupational therapist who, similar to Van Dyke, back in the 60s and 70s, came up with an idea and an approach that she called sensory integration. And I'll say quite a bit about that later on in this presentation today. She came up with a theory about the way sensory integration develops in infants. She talks about the idea of sensory modulation and enhancing and inhibiting. I will say more about all these things later, but the idea that we're being bombarded with sensory information all the time, and we have to enable our brain to ignore some of that and pay attention to some of it. And we have to be able to change where our attention is going very rapidly, depending on changing circumstances. She also promotes the idea of observing children very closely, especially to see which kind of sensory inputs they look for and which kind of sensory inputs they avoid. And that gives the therapist a very good idea of what to work on and where to start working. Not from herself, but from her successors, especially an OT called Pat Wilbarger, the idea of the sensory diet. And I will talk about that later as well. The idea that we all have a need for particular sensory inputs at particular times for particular reasons. And I won't say any more yet. And also, she talks about the connection between sensory inputs and levels of arousal. I talked about levels of arousal already, but I will go on to that in a little more detail today when I talk about self-stimulation, especially. So they are my three big gurus, I would say. And I think we can appreciate that there are many, many other people, of course, who have influenced us and helped us to develop our understanding. But for me, these are my three main people, as it were. If I put them all together, they're a very disparate group. They didn't ever work together. And certainly when I spoke with Lily Nielsen, she didn't know Jean Ayres, and she didn't have a major interest in Van Dyke. And when I spoke to Van Dyke, he had no interest in the work of Jean Ayres or Lily Nielsen. And I wonder sometimes if that's part of being the magic of being a guru, possibly, is that you have your own areas and your own strong opinions and strong feelings about things like that. They, as I've said, they were all very child-focused. They were all child-led. They were all hands off, at least in the initial stages of working with the child. They all pushed the idea and the need for close observation, and then meticulous interpretation, usually shared with other people. They all have a focus on guaranteeing success, good teaching and good therapy. When you help to create challenges for the child, you do want to guarantee that the child can somehow adapt their behavior and meet the challenge. They all, at different times in different language, focus on the child's positive self-image and self-confidence. And they all recognize that sensory functioning depends upon many, many issues. And not coincidentally, all of these three professionals were mavericks. In their time, they were all very opposed to the received opinions about what was right and what was appropriate for the population of children that they were working with. And I think that's probably why they appeal to me, because I also have had some problems fitting in with establishments, shall we say. So it's good to remember that in reality, everything joins up. In these webinars, for example, I've talked about the senses of proprioception and the vestibular sense. I've talked about assessment. I'm talking about self-stimulation. I'm talking about self-regulation, as if these things are neat, self-contained, quite discrete topics. But actually, everything joins up. And by nature, I'm a synthesizer. So if I'm focusing on one thing, I start to see connections and my brain starts to wander and I get very distracted. And I made this slide just to remind everyone that things like self-determination, sensory perception, the child's self-image, emotional competence, the attitude and the behavior of other people, self-regulation, executive function, availability for learning, previous experience, expectations and motivators, communication and language, and so on. All these things join up and they all have an impact on each other, so that you may feel that you're working with a child on one particular thing, one particular area, but in fact, you may be impacting many other areas of development, positively or negatively, depending on the situation. In the deafblind field, we have a series of imperatives, almost like orders. And I've made a list of them. There are more, but I felt these were the most important. Follow the child, know the child. And last week I talked about personal passports as a practical demonstration of knowing the child, getting to know the child through your assessment process. Individualize is another big one. Do with, not for, which fits in very much with the views of my three gurus. Create conversations in every interaction, regardless of whether language is involved or not, and use a multisensory perspective. Think multisensory all the time. If we think about perception, this is a quote from an old book now from 1984, which I happen to like very much. I'll read the quote. "The brain, the organ that is responsible for your conscious experience, is an eternal prisoner in the solitary confinement of the skull and must rely on information smuggled into it from the senses. The world is what your brain tells you it is, and the limitations of your senses set the boundaries of your conscious experience." And I've already talked about this idea in previous webinars. The idea that the brain is connected to the body and the world around it through the senses. It's only the senses that provide information so that the brain can know anything at all about where it is, what's around it, what's happening. And that includes helping the brain know what its own body is doing. There has to be information coming in through the sensory systems and feeding the brain with all this information. And equally, when the brain tells the body to do something, the senses have the job of feeding back so that the brain knows the body's done what was wanted and that it's worked, or it hasn't worked, and there's a need to try again. There's a need to do it faster, or to do it a little lower, or to do it a little further away, or whatever. And this idea tells us that, for example, we don't see with our eyes, we see with our brains. We need eyes to collect visual information, but it's the brain that does the active seeing. It's the brain that interprets what's being seen, makes decisions about it, and then responds appropriately. And that means, unless you're an eye specialist, if you're assessing a child's vision, it's good to think about the whole child rather than just their eyes. I see people, when they're trying to ascertain a child's visual abilities, focusing almost exclusively on the eyes, and they may well be missing all kinds of things if they're not pulling back a little and getting the whole child into their field of awareness. And equally, we don't hear with our ears, we hear with our brains. And this means that we need to be much broader in our observational skills than just in the very narrow traditional ideas about responses to vision or responses to sound. The good thing and the bad thing is that brains are much more complicated than eyes and ears. And one of the biggest complications and one of the biggest differences is that brains experience emotion. Brains experience memory. Brains have feelings, which eyes and ears are not capable of. On the positive side, that means that if we're seeing with our brains rather than our eyes, we can sometimes see things which our eyes can't. And I've got a couple of pictures. And the idea is these are meant to be humorous. And this picture is only humorous because our brain is seeing something that our eyes actually can't see. This is obviously a Starbucks van, but because the sliding door is open, much of the name disappears and you end up with the word sucks. And if you don't rate Starbucks very highly, then it's particularly funny because the word it spells is sucks. But my point is, your brain is actually seeing things that aren't visible to the eye. And again here, it looks utterly bizarre, except we know by previous experience, we know what's happening in this photograph. So it isn't actually bizarre, but it's funny because it looks kind of as if this nose and mouth is attached to that pair of eyes and ears. And here's another one, and another one, and another one. So the fact that it's the brain that's doing all the active interpreting rather than the sensory systems does give us certain advantages in terms of memory and experience. But also there's added complication because of the presence of emotion and feelings. And it's our emotions that really coordinate the mind and the body. We know that our emotions can be very, very powerful. And we know that in young children, emotional maturity has not developed yet. And if anyone listening has raised a child, you will know that in a big, big way. And that it takes years for children to develop emotional competence and emotional maturity. But the coordination that that is needed and that develops is important because it's our emotions that help us to organize our sensory perceptions, our thinking, our memories, our physiology, the very way that our body is working, our digestion, our breathing, our body temperature, our muscle tone, and even our sensory, the acuity of our sensory perception is affected very intensely by emotion, our behavior, and our social interaction. Natalie Barraga was a major personality in the visual impairment field internationally, but especially here in the United States. And this is a statement from her where I've picked out certain words. She says, visual functioning is related in part to the condition of the eye. More explicitly, visual functioning is determined by the experiences, motivations, needs, and expectations of each individual in relation to whatever visual capacity is available to satisfy curiosity and accomplish activities for personal satisfaction. And the words I've picked out are the ones related to the emotional heart of the child: experiences, motivations, needs, expectations, satisfying curiosity, and feeling personal satisfaction. And what Barraga is actually saying is, for example, if you go into a room of children with visual impairment, the child with the best functional vision might have the least vision of all the children in the room, but they are the most driven, the most ambitious, the most assertive, with the highest expectations of themselves in the group. And the same with hearing impairment. In a room full of deaf children, the child with the most clearly articulated speech won't necessarily be the child with the most hearing in the group. They might be the child with the least hearing, but the most assertive, the most well-trained, the one with the highest expectations of themselves and the highest motivation to hear and to speak. So it's a bit like complication on complication, but these are good things in the long run, even though it gives us, as educators, a lot more to think about. This is a slide I've already shown, just a reminder that when I say multi-sensory impairment and multi-sensory issues, there are many more senses than the classic 5 senses. And in this slide, I've added perception through the proprioceptive sense, perception of temperature, perception of pain, and perception through the vestibular sense as a reminder that we have many more senses than just the traditional 5. And I've talked in quite a lot of detail in the first webinar about vestibular and proprioceptive senses. When our senses develop, it's the central nervous system, the brain, which plays the key role in getting information from all the senses, attending to the information or disregarding it, interpreting it, and then seeking out more or avoiding it. It's the brain that does that, but the senses have to be there collecting the information and conveying it to the brain. And then an interesting fact, this process of receiving sensory information begins before birth and is unique to each individual. After a normal pregnancy, a newly born baby already has experience of processing sensory inputs, regulating their own arousal levels, and self-stimulating. And because we now have the ability to use scanning technology, we can observe a fetus over time, and we can notice the development of these abilities as the fetus grows and develops. And we know, for example, that fetuses move, that they improve the quality of their movements so that the movements become much more obviously controlled and voluntary. We know that they may well find a hand with their mouth or find their mouth with a hand, and they can even put the thumb in the mouth. And then at some point, they're quite likely to discover the other hand and even alternate sucking on one thumb and then sucking on the other. We know that a fetus can move in response to environmental sound, rhythmic sound. If a pregnant woman is at a party or a wedding or in a nightclub, they often report that with a strong beat to the music, especially with a very strong bass, that the baby starts to move, almost dancing to the rhythm. The chemical senses of smell and taste actually play a part in fetal perception because the fetus is taking in fluid all the time. There are chemicals in the fluid from the mother's body, from the air she's breathing, things she's putting on her skin, the food she's eating, and the drink that she's drinking. And those chemicals are stimulating the smell and taste receptors before the pregnancy comes to term and the baby is born. The only real exception to this, of course, is vision, because the womb is a dark environment. And that's the reason why when babies are born, their vision is much less well developed than their other sensory abilities. And it takes a newborn baby quite a long time to improve their distance vision, especially. And in the beginning, things need to be very close to them. Although all the sensory systems are unique, there are some fundamental similarities. And as I've said, every system is responsible for collecting and conveying information from the environment to the brain for processing. And by environment, I mean everything, including the child's own body. And there may be three kinds of obstacle. The sensory receptors might be faulty in some way. The nerve pathways that connect the receptors to the brain might be faulty. And the brain itself might be faulty through malformation or brain damage. And many children in our population have all three of these kinds of difficulties. Every sense is designed to work simultaneously with all the others for maximum efficiency. And if other senses are not working properly or are missing, senses which are intact will become potentially more important, but also more challenged. So information comes in through the sensory systems and is processed for two reasons: to make us aware of stimuli in the environment, and as occupational therapist Winnie Dunn says, to construct maps of self and environment for organization and planning. Jean Ayres, one of her genius theories way back, was that the environment has a crucial impact on brain development, that the brain changes in response to external stimuli, and that experiences resulting from sensory inputs and the child's responses to them affects brain development. When she was saying this, it was thought to be crazy. She took a lot of criticism for her ideas, including this one. We now know, of course, that she was absolutely right. And it's almost hard to believe that well within my lifetime, people didn't believe this and thought that the child was born with a brain that was kind of set and just needed to learn things from experience, but that the brain was what the child had, and there was nothing that could be done about it other than what education could achieve. So let's think about self-stimulation. I'm really going to rehabilitate self-stimulation in this presentation. Self-stimulation has a very bad reputation in education, and especially in special education. When I go into schools, probably the question I'm asked most often is, how can I help them stop the child stimming, as people put it, meaning self-stimulating? And when I ask, what does the self-stimulation behavior mean? People look at me in confusion because they've never even questioned what it means. It's seen as an entirely negative thing which needs to be stopped. And I understand that over time, sometimes children's self-stimulation behavior can become very severe and very intense and can actually be damaging. And that's not what I'm talking about today. That's a whole separate later issue. And I'm well aware that there is extreme self-abusive behavior, which we do need to try and stop as quickly as possible. And I'll mention that later in the talk. But let's think about self-stimulation and almost in the abstract and not be judgmental about it. First of all, think of the constancy of sensory feedback, that our brains are being bombarded with sensory input through our sensory systems all the time. I would say self-stimulation is any sensory input that we seek, which is not directly the result of a specific activity, whether that's making coffee, drinking from a glass, getting dressed, walking, reading, or whatever. It's really any sensory input through any sensory channel that we seek, which facilitates our functioning. It's very personal, it's totally individualized, and we self-stimulate usually without even realizing that we're doing it. And these are my thoughts about sensory inputs and self-stimulation. As I said, the constancy and the interrelatedness of all our sensory inputs. It's the senses that connect the brain to the body. We know that sensory inputs have a very significant and direct impact on arousal levels. We know, in fact, that sensory inputs can be immensely powerful and even dangerous. And this is a good time to remind everyone that if we are administering sensory inputs to a child, especially a child with complex multiple disability, who maybe doesn't have a lot of voluntary movement, doesn't have a lot of expressive behavior, certainly may not have language or very well-developed communication skills, we need to be very careful and very observant that we're not creating potentially negative, dangerous situations for the child through the sensory stimulation that we're providing to them. Some senses may be more important to us than others at certain times, and that's absolutely normal. And there's nothing inherently wrong with children who seem to hear or see better some days than others, or at some times than others, because vision and hearing depend on far more than just the eyes and the ears. I talked in the other webinars about my belief that most children with deafblindness are not in touch with their bodies very well, or don't feel their bodies very well, precisely because of their multi-sensory impairments. We all self-stimulate to maintain alertness, to wake up, to calm down, to maintain postural control, to get comfortable or to keep comfortable, to occupy our minds, to self-regulate, to fight boredom, to maintain attention, to keep sane, and generally to improve our functioning to achieve our goals. You can't see me, but as I'm sitting here, I am rocking forward and back slightly, specifically because in some way it seems to help me keep going and keep focused on delivering this webinar. I also am altering my sitting position fairly frequently, which again is helping me to self-regulate. It's helping me to focus. It's helping me to keep calm. And it's also reminding me not to talk faster and faster and faster because I'm looking at the clock. I'm aware that I've now had 45 minutes and I have a lot to cover and time is passing. So self-stimulation is essential. It's essential to all of us all of the time. And the idea that stimming is bad is complete nonsense. Stimming is vitally, crucially important. Let's get that very clear. Then my next bullet point, I'm well aware that sensory deficits and poor sensory perception, especially poor multisensory perception, make children with deafblindness self-stimulate in mostly normal ways, but often with more intensity, more persistence, and for a longer period of their lives than what we would call normal. The biggest exception, I think, I say in mostly normal ways, children with low vision often have visual stimulation behaviors which are fairly unusual outside of that population. And I'm thinking specifically of poking the eyes with one or both fingers or pushing the knuckles of a fist into the eye. These, of course, are not particularly seen outside of the visual impairment field. But things like rocking, spinning, bouncing, head weaving, hand flapping, hand squeezing, crossing the legs, folding the arms, bouncing the legs. All these things are done by almost everyone at some point for particular reasons. They are not exclusive to children with disabilities. And we need to keep moving away from that judgmental view that self-stimulation is somehow bad and needs to be stopped. I'm aware that the intensity and persistence with which children with multiple disabilities self-stim can be very stigmatizing. It can also be a block to attention and learning, but I think that's an issue we need to address in terms of why is this child trying to block me out by self-stimulating? Because it may well, if we turn that question on ourselves, it may well be that we're not really thinking about their motivators. We're not really making things interesting and relevant to them. For various reasons, children with deafblindness may have poor social awareness, so self-stimulation behaviors may be much more obvious. They may do these things in very public situations where if you could see me at the moment, I probably wouldn't be rocking quite so much. In fact, I'm sure I wouldn't. I would be self-monitoring and trying to look much more professorial and professional in my seating posture. As it is, you can't see me, so I don't need to worry. So I can just let rip and move around and weave my body around to help myself concentrate and deliver. Attempts to stifle and stop self-stimulation behaviors may result in worse self-regulation and generally less good functioning. And there's nothing for me more concerning than watching someone with a child. The child begins to flap his hands and the person takes his hands and pushes them down to his lap and may even say, no flapping. It shows a misunderstanding of where hand flapping comes from and what it's for and what it probably is achieving for the child. But it also shows a lack of interest in interpreting the child and taking the child to a situation where they perhaps don't need to be flapping their hands quite so much or quite so openly or quite so intensively. And I say in the last bullet point, observing how and when a child self-stimulates will offer invaluable insights into who they are and how they work. And these insights can help us with our assessment, our teaching, our behavior management, and our relationship building. So, what do I mean by self-stimulation? Well, almost anything. I've already mentioned hand flapping. I've mentioned rocking. You think about young infants as they develop. You think about when the first time the baby sees her hand, and suddenly there's a period of intense hand regard and finger regard and finger play. And those kinds of behaviors are seen very often in children with visual impairments or low vision, but not just as infants, but maybe as they get older as well. Then they find their feet and they bring their feet up and they put the toes in the mouth. Then they bring the other foot up and put the toes in the mouth. Then they clap the hands. Then they rock side to side. Then they bounce their head. All the kinds of things we see in deaf-blind children, other than probably those visual impaired eye-poking behaviors, are seen in all children, I believe, as they develop. But there are also behaviors like striding back and forth. When I'm waiting for the tea kettle to boil to make tea, I often pace one way and then the other in the kitchen. Entirely meaningless, apparently, entirely a waste of my energy, but it helps me pass the time while I'm waiting for that kettle to boil. And I can't see you, but if we were all in the same room at this point in this presentation, I would comment on the fact that I've seen somebody in the room is an ear puller, somebody else is a leg bouncer, somebody else is a pen twiddler, somebody else likes to wind their hair around their finger, somebody else is playing with their necklace or the pendant that they're wearing around their neck, and so on. I love to notice people self-stimulate, ready for when they say, how can we stop this child stimming? And then I like to say, well, I notice you're self-stimming. Why do you do it? Or how would you replace that behavior? And I talked in a previous webinar about the fact that in interactions with the world and communication in the broad sense of the word with the world, first of all, the brain has to communicate effectively with our own body. Then we can start to have the brain communicate with the immediate environment. And then as we develop and extend our skills, our brain can start to communicate with the wider world. So when we see a child doing this, rather than sitting on a chair or on the couch, squeezing into a tight box where she hardly fits in order to watch a video or play a video game, this is self-stimulation. The posture, the squeezing, the compression is self-stimulation. Seeking sensory inputs that are not directly related to the activity itself. And I talked about this in the first webinar, but we need to look at this and say, this is serving an important function for this child, and we need to work out what the function is and see if that helps us work with her more effectively. When babies and infants cross their fingers, very unusual behavior, but quite commonly seen in certain children with deaf blindness, this is telling us something about them and about their brain's connection to their body and about their need to connect the brain more effectively by exaggerating and increasing some of the sensory inputs coming from their body into the brain. This is self-stimulation. Here's a boy waiting to see the doctor. This photo came to me only last week, I think, where you and I would probably sit on a chair, part of which, of course, would be social conditioning. This boy likes to get into this position. Again, this is self-stimulation captured by the camera. So it isn't just eye poking, it isn't just rocking, it isn't just hand flapping, it isn't just hyperventilating. It's all kinds of behaviors which create sensory information that goes to the brain for some specific reason. And yes, I believe that posture should be included as a self-stimulation and, in many cases, a self-regulation behavior. And if I go back for a moment, if you think about your brain not being connected to your body very effectively, anything you do with your body that increases the quality of that connection, any sensory input that you create in order to give your brain a better idea of where your body is and what your body's doing, I believe is going to be innately self-regulating. You are putting the brain in a much better, much more highly informed position about where you are, where the body is, and what it's doing. And I think that is probably innately self-regulating and could be calming or arousing depending on the situation. And when it comes to self-stimulation, I would say if what the child's doing is not dangerous or illegal, we should be asking, what does it mean? And then when we intervene, we should be trying to answer that question. We should be trying to ascertain, what does this behavior do and what does it mean? And why is the child doing it? We shouldn't intervene in the first instance to try and stop the behavior as our primary goal, unless it's dangerous or illegal. And that's a really important point that I want to make. There's far too much stopping children stimming before anyone's bothered to work out what the stimming behavior means. And that is a dead-end approach. First of all, you won't stop it. It won't work. And if the child stops that behavior, they'll have to revert to some other kind of behavior for the reasons that they developed the first behavior. This is a list I made in some desperation about 3 years ago. I called it urgency of intervention questions. So when people are complaining about stimming behavior, I suggest that they observe, record, analyze, and discuss the behavior to try to interpret it, and then answer these questions in increasing order of urgency for intervention. The first one, is this a behavior that just bugs you personally so that it can be accepted and ignored? And I have to say, I've got very used to going into classrooms where I'm asked to help stop a child doing something, and it's something that just personally bugs the teacher or the classroom aide who's making the request of me. I went to a classroom and a boy, whenever he was filling in time, waiting for recess, waiting for lunch, waiting for bathroom, would purse his lips in a very extreme way, over and over again, rhythmically. And they wanted me to help the boy stop doing this. And I asked what it meant, and nobody knew, and I don't think anyone cared what it meant. And it was completely inoffensive. It was bothering no one. It's the kind of behavior I probably do. I don't know. I haven't looked in a mirror, but I do all kinds of things that aren't strictly functional, but they do help my functioning. That's the point. So that would be an example of a behavior that just bugged one of the adults in the room. And you're just got to get over it and ignore it. There's far too much else to work on to bother about those things. Secondly, is this a behavior that seems to help the child to function in a positive way so that we can accept it and then ignore it? And a lot of things would come under that heading. Thirdly, is this a behavior that seems to help the child to function in a positive way, but it could be reduced or replaced by another better behavior? Maybe we know something that will, according to our interpretation of what that is doing for the child, we could give them a better way of doing that. Then there's a situation number 4. Is this a behavior that's undesirable and needs to be reduced or replaced over time? It's a little more urgent, and we need to work out the meaning so that we then have ideas what to replace it with. And then the last one, is this a behavior that needs to be prevented immediately? And that's a tough question to answer beyond yes, because sometimes these behaviors are very deeply ingrained in the child. They become very habitual, especially with older children and increasingly with teenagers and then adults. And it can be very, very difficult to amend and modify these potentially injurious or dangerous behaviors. I've talked about the body and the brain being separated, not being connected effectively. And I did talk quite a bit in the first webinar about some of these things. But if you're trying to improve that connection, it's very individual. It depends on the individual child. But of course, it also depends on you as an individual and the context, the situation you're in, the space and the environment and the resources and the expectations that you have. So any activities which improve muscle tone and controlled movement and reinforce the body-brain connection, things like Tai Chi, yoga, climbing, dancing, and so on. Deep pressure inputs like jumping, deep pressure massage, swimming, bouncing on a trampoline, binding, such as a spandex pressure vest, which might be provided by an occupational therapist for particular periods of time. Good physical supports and appropriate postures for efficient functioning, and especially good seating. Getting the seating evaluated by a PT or an OT, and maybe getting a chair that's specifically for that child to give the kind of supports that the evaluation suggests would be needed. Variety in postures and movement, especially for children with limited movement abilities. Rest periods for reorganization. And remember that rest periods with this population could be the opposite of what we think of as rest. Some children will need literally to rest. They may need to lie down and get horizontal, but they may also need to jump, to spin, to run, to rock, and do some fairly dramatic movement in order to reorganize. Controlled environments, think about the environment and trying to minimize distractions as much as possible. Looking at the child's self-taught strategies and encouraging and facilitating those, but also teaching strategies to improve the body-brain connection. Think about strategies that are motivational for the child and appropriate vocabulary. I think we need to tie in our language work with this population far more to these issues of self-regulation and self-stimulation. Think about perhaps early vocabulary for body parts, for physical feelings, for emotional states, and for desired activities. These things are not abstract. I've sometimes suggested that maybe introducing vocabulary for emotional states and feelings would be a good idea. And I've been told more than once that it's felt to be a little early to introduce really abstract concepts. And people prefer to use vocabulary relating to concrete objects or concrete activities like home, bus, bathroom, lunch, and so on. And I always respond by saying, well, emotional states are not abstract. They're absolutely central to the child. They couldn't be more central and more important. And this slide, these two slides encapsulate a main message of this presentation. And I will come back to many of these bullet points again in the remaining 55 minutes that we have. Let's think about stress. Now, I've talked about self-stimulation. Let's think about stress. Stress helps us to work out and try to deal with many challenges that life presents to us. If it's time limited, then it's a normal and indeed an essential process. So again, there's a common assumption that stress is bad, where actually stress is crucially important and can be very, very good thing, but it does need to be time limited. It protects us from harm, and it also helps us learn to protect ourselves. Without it, we would fail to acquire many vital life skills. And stress, good stress, helps us to take risks and build skills. It helps us learn how to cope and how to remain calm but alert, which is a kind of thumbnail description of good self-regulation. It provides us with opportunities for acquiring a memory bank of successful strategies. It helps us to develop effective problem-solving abilities. It keeps life interesting, and it provides motivators and an increasing range of motivating challenges. Walking independently and unsupported, jumping off the couch, watching a horror movie, climbing a mountain, giving a conference presentation. The stress involved in those things is positive stress. And you see this in children as they develop standing and weight bearing and walking. It's a challenge, it's scary, but the good stress is there to provide motivation. And here's a cartoon. You've got a doctor talking to a patient, and he's sitting on the examining couch with a cigar and a large glass of brandy, looking very relaxed. And the doctor says, you should relax less. In other words, you need some positive stress in your life, because otherwise you're going to have health issues developing from this extremely relaxed attitude that you have. So when and why can stress be bad, and why has it acquired this reputation of being bad? Well, it should be time limited to be helpful, as I said, and extended periods of stress result in stress hormones remaining active in the body for much too long, and they can cause damage to the body. The developing infant brain is especially at risk. Prolonged stress can result in a whole range of health issues and functional issues like blood pressure problems, heart disease, diabetes, depression, and associated self-abuse like drug abuse and alcohol abuse, poor memory, and a range of other mental health issues. And the inability to deal with stress effectively leads to feelings of helplessness and may keep an individual in a state of hyperarousal or hypoarousal. In other words, hyperarousal, way too stressed and anxious and possibly hyperactive and distracted and inattentive. Hypoarousal, far too switched off, far too drowsy and inattentive. At this website, the National Scientific Council on the Developing Child, there are some very interesting brochures about stress and about infant development. And the one I'm particularly referencing here is called Excessive Stress Disrupts the Architecture of the Developing Brain. There's also a college professor in Utah, Kathy Nelson, who in previous years has given webinars for the Idaho Clearinghouse. She has a special interest in stress and has produced some very interesting research. Not by chance, she's a close collaborator with Jan van Dijk. And I would recommend you look up her work if you're interested in following this through. My next slide is from some of Kathy Nelson's work. She says that the factors which help to protect a child from negative stress are secure attachment with at least one other person, good physical health, a strong social network, responsive environments, feelings of competence, clear patterns of arousal and relaxation, physical exercise, relaxation opportunities, and temperamental characteristics. And if you know, I presume if you're watching this webinar, you know about deafblindness or you know about complex multiple disability, you look at this list and you instantly, with each bullet point, you can see that these protective factors are probably missing or inadequate for most of the children in this population, unless we have actually taken steps to make up for that deficit and to try and provide these protective factors. So I believe stress is inherent in complex multiple disability and deafblindness because we are not designed to have multiple disabilities in a sighted, hearing, busy, high expectation world of independent people. I think it's good to remember that stress is probably there at levels we might be surprised by if we could perceive it in the children with whom we're working. Now I'm going to talk a little bit about emotional intelligence and come back to the implications with stress. I'm not going to say too much about this again because of lack of time. I see we only have 45 minutes left. But again, I would recommend you get on the internet and look at some of the work on emotional intelligence or emotional maturity. And this is one author, Paula Ford Martin, who I like. She talks about identifying emotions, understanding emotions, managing emotions, and using emotions. And the first one, I would say, identifying emotions, relates very clearly to what I just said about early language work. Giving children access to vocabulary about emotional states and about feelings and about body parts and the way that those things relate to our arousal levels and our feelings. Understanding the emotions is going to take some work with most of the children in the deafblind population, and then helping them learn to manage and use their emotions can be quite a long-term prospect. But this really should be in the curriculum right from the beginning. I've worked with babies as young as 6 months old, where I've been talking to the family about these issues and starting them along the road of thinking about working on these things with the child. If you look at work on social competence and emotional competence, again, like I showed you Kathy Nelson's list, they they many authors talk about these concepts and the need for them. And again, you can see how much our population of children falls short of these things. First of all, feeling safe, secure, and understood makes successful learning possible. And that idea, feeling understood, is an important one that I haven't mentioned. The need for the child to know through experience that they've been understood, that something they've done has been interpreted correctly by someone else who has responded in a way that confirms for the child, yes, I did that. The adult-child relationship is the key to the child's resilience, the need for attachment. And that is something we have worked on a lot, I feel, in the deafblind world fairly effectively for many years. Physiological, emotional, and behavioral resilience is the key to development. Nurturing caregiving provides genuine dialogue for the development of attachment and mastery of self-regulation. Now, these comments are from the literature on social competence and emotional competence, nothing to do with disability or deafblindness, but you see, the idea of dialogue comes in very early, the idea of conversation and the need for a conversational structure and turn-taking pattern in every interaction with the child. And brain research shows that lack of goodness of fit may lead a child to be prone to distress and to increased regulation problems. So they talk about, in quote marks, goodness of fit. Let's think about what that means. Goodness of fit is thought to be critical to effective brain development, critical to secure attachment, and critical to eventual self-regulation of emotions and behavior. And goodness of fit develops if the child can demonstrate their physiological and emotional needs, and familiar people can note and respond to these needs. In other words, there has to be someone around who understands you. And there's a challenge with children with complex multiple disability, including deafblindness. The times I've been told by a parent, I don't really understand my child. And I can understand them saying that. But there's something there we need to rectify. And I would say I'm not talking about working with families officially at the moment. But to me, when a parent says that to me, I feel there's an urgent need to reflect back to the parent how well they actually do know their child. They do know their child, but they might not realize they know their child, and they might not realize how well they know their child. So that quickly becomes a focus of my work. And goodness of fit occurs naturally if the adult has learned to read and respond to the infant's cues, and if the adult's current life circumstances are not overwhelming and provide the necessary social, emotional, and economic support. So the first part of that sentence is about learning to read and respond to the child. The second part is about the adult, and predominantly, of course, parents and family members, needing to have lives that allow them to feel supported and available. And we know that that might not be the case, particularly if the baby has very high level medical needs or very high levels of challenging behaviors. And I have a cartoon. The guy is watching television with his pet, and he says, sometimes when I watch a comedy, I find myself laughing in all the wrong places. And his pet says, you mean places other than your mouth? And obviously what the guy means is I laugh at the sad bits because I have poor empathy. But the idea of laughing with places other than your mouth really struck me, because the children I work with laugh with their whole bodies. They often laugh with their feet. They laugh with their fingers. They laugh with their butt. It isn't always a smile. It isn't always an audible laugh, but they express their needs and their emotional state in all sorts of ways. And they're likely to use any part of their body to do that, rather than the conventional behaviors that we're all brought up to be useful. What are the risk factors for developing good emotional and social competence? And this is almost like a descriptive list of deafblindness. The child's temperament is intense. Cues are sporadic or resistant or inconsistent. The above may lead to increased sensitivity, proneness to distress, and self-regulation issues. Neurological and sensory difficulties may interfere with attachment. Multiple issues result in altered social and behavioral competencies in both infant and adult. And social and environmental issues impinge on the infant-adult duo's ability to interact in typical ways. And those last two bullet points go back to that question of, is there an adult involved who's freely available to the child? Or are they not competent, not least because of the child's complex multiple disabilities, which has left them with growing feelings of incompetence and inadequacy? So these are issues that we really need to address quite separately to the more traditional central issues in education of skill acquisition, and particularly in those central curriculum areas of communication and language, literacy, numeracy. This is a piece of paper that was sent me by a parent many years ago. Her son had Charge syndrome and was in his mid-teens. He had a lot of challenging behaviors and very poor self-regulation. And one day he went to school and his mother found this on his bed, this piece of paper. He'd designed it himself, he'd drawn the lines, and he'd written these questions in, and then he'd folded the paper, left it on the foot of his bed where he knew his mother would find it. This is a boy with quite good levels of language in sign language, but these are questions he was never able to ask directly, because I think they were too profound and too painful and too emotional. And in his very deaf English, he says, "Why are I die when I was born?" Meaning, why did he need oxygen and ventilation and suction? Why you think I has died when I breathe because of breathing difficulties? Why are I very naughty at school? Why are I play with my hair? He was pulling clumps of hair out. Why I got nosebleeds? Why are I be deaf? Why are I grind my teeth? Why are I hit people? This is a huge step for this boy to be able to write, even to know that these are the questions that are driving him crazy and that he wants help with, and that he realized he could write them down and leave them for someone to find. And very soon after his mother found these, the school set up a plan whereby they took one question a week and did like a little project on his birth, the resuscitation that was done, what is a ventilator, what is a suction machine, why do people get nosebleeds and why was he particularly prone to them? What does grinding the teeth mean? Why does he hit people? And of course, because this was an older child with language, he was able to be very actively involved in the way this sequence of sessions was designed for him. So back to stress. Given the idiosyncratic behaviors of the children. It's good to think, what does stress look like in this child? Because it might be laughter, it might be smiling, or it might be a generally very impassive face, not least because there might be facial palsy in the child. So how can we start to recognize stress before things get to a switch off or an explosion level? What kinds of things create stress? When does it happen? And what helps to reduce it? And this is where something like a personal passport, which I talked about last week, or a video portfolio can be a very helpful approach to helping to answer these questions and then share the answers with other people. Now I'm going to move on at last to self-regulation. A lot of work has been done on self-regulation in children with Charge syndrome by Jude Nicholas, who is a neuropsychologist, and Tim Hartshorn, who is he's actually a psychology professor, but he also has an adult son with Charge syndrome. And this is from one of their articles, Self-Regulation in Individuals with Charge syndrome. They say, self-regulation may be defined as the capacity to manage one's own thoughts, actions, feelings, and physiological states in adaptive and flexible ways across a range of contexts. Self-regulation involves both the initiation and the maintenance of behavioral change, in addition to inhibiting undesired behaviors or responding to situational demands. It's very complex, and you have a number of their articles as handouts, and I recommend that you go to them if you want to learn more about this topic. It would be very helpful as a start. I would also recommend, incidentally, that you go to the website of the National Centre on Deafblindness, NCDB, where you will find masses of information in their library, including lots of information on this topic, on challenging behavior, on self-regulation, on sensory stimulation. Tim Hartshorn talks about self-regulation in these terms, that crucially important is managing the threshold of arousal. And I will talk about arousal in a moment. Processes of self-control, that effective self-regulation both suppresses and encourages, both inhibits and promotes. It's about stopping certain things and starting other things, or not doing certain things and doing other things. Self-regulation supports homeostasis of the system, homeostasis meaning a good, effective balance in your whole system of your whole body and the way it's working. And self-regulation is critical to development. And if it's not present, that presents huge obstacles to availability to learning and development. This is Tim's idea of showing a well-regulated and poorly regulated photographs of two kitchens, one of them beautifully clean and organized, the other one chaotically disorganized, a terrible, terrible mess. And if you are fairly well-regulated yourself, you'll probably look at this second picture and get goosebumps because it looks so horrible. You just want to go in there and clean it up or leave and get away from it. The articles that Hartshorn and Nicholas have published were all put together. They came out in Deafblind International Review, and they were, last year, they were all put together in a large format monograph by Deafblind International. This is the cover. And the articles that you have as handouts were taken from here. And in a nutshell, and I'm not doing this much credit, but because of lack of time, but they propose a 4-dimensional model for self-regulation. And they split it up into self-regulation of cognition, self-regulation of behavior, self-regulation of emotion, and physiological self-regulation. And I'll say a little bit about each of those. But as I say, if you're interested in this, I really recommend that you look at the articles. So the first one is self-regulation of cognition. This means regulating your thoughts and your mental processes to try and get a good balance between inhibition and initiation of behavior, between stopping some things or not doing some things and starting and doing other things in order to achieve your goals. It's to do with regulating your attention, shifting your attention from one thing to another, which is often a problem for children with complex multiple disability, updating your working memory, and self-monitoring, being aware of what you're doing and how you're doing it, and knowing when you need to modify that. It's also about cognitive flexibility. What I would call, they call cognitive flexibility, I would call probably problem solving for shorthand. You can use scaffolding, which is a well-known educational approach to support a child. It comes in a whole range of forms. You can use things like task analysis, planning, rehearsing activities, creating menus or recipes with the student to help with their memory deficits, and manipulating and adapting the environment to minimize distraction, but also to support and facilitate attention and learning. It's important to remember the huge importance of motivation, and children will develop self-regulation of cognition far more effectively if they're being asked to do or given to do activities which are inherently motivating for them. It's also good to remember the idea that I talked about in the first webinar of preparing a child in advance for attention and concentration, using things like deep pressure massage, rhythmic movement, Tai Chi, yoga, or whatever. So the next bullet point, self-regulation of behavior. The child has to be aware of their behaviors. So working on awareness of behavior, working on quantifying and qualifying and labeling behavior, and choosing behaviors which most help to achieve a goal. The importance of motivation, again, applies here as to everything, and the ability especially to delay gratification. This is a difficult skill for children to acquire, and that often needs to be taught in a very structured way. If you look at the handout about charge behavior, there's an article about charge behavior, which I was one of the authors of, which you have as a handout. And in that, we suggest investigating challenging behavior under the headings of pain, anxiety, and sensory issues. And that kind of breakdown might also be helpful for you. It's not unusual for an educational setting to develop a personalized behavior plan for a child, but this will need to be very individualized, and will also need to take note of deafblindness and multisensory impairment issues, and also stress reduction by us, stress reduction and anticipation work, doing things like manipulating the environment or helping the student to create calendars or schedules of activities of the morning or the day or the week, depending on the child's level of ability are all part of it. Self-regulation of emotion, really, this means how can we help the child learn to respond to the demands of their life with a whole range of emotions, which are socially acceptable, but also flexible enough so that they can utilize their emotions, perhaps in a more spontaneous reaction to what's happening. This is partly internal, but also obviously part of a social process. And there needs to be a good fit between the child's temperament and the social context in which they are existing, be it home or in a classroom or on a hospital ward or wherever. And that idea of goodness, of fit, comes in a big way here. The child needs to be aware of emotions and able to recognize them. So vocabulary for labeling emotional states, working on arousal levels, possibly using techniques like modeling, revisiting and reflecting on emotional states, and using calming techniques, which could include, again, massage, movement, Tai Chi, yoga, maybe breathing techniques, or even helping the child have a safe space where they can go and regulate their emotional state, maybe with help from us. And then the last one, physiological self-regulation. This applies to the ability to alter your states and responses to meet the needs of the body. I've used a number of techniques at 2:30 today in San Francisco time to get myself ready for this webinar at 3 o'clock. I didn't need to do that earlier in the day because I was doing some reading and writing on an entirely different topic. But I knew I had to get myself ready for this 2-hour presentation. I think normally our physiological self-regulation tends to be out of our control and out of our awareness. And it's really a combination of our somatic nervous system, the endocrine system, and the autonomic nervous system, which take control of this. But self-control also plays a part in it. Sensory integration is very important in this area, and the stress response systems that the child has are an important part. I discussed some of these things in the first webinar, but I'll go on to sensory integration in a moment. Again, environmental management, postural supports, sensory inputs, increasing them or minimizing them, sensory integration strategies, and management of diet may all play an important positive role in these things. So that was just a quick overview of the kinds of things you'll find in the articles. Tim Hartshorne talks about managing the threshold of arousal. And he, again, in many of his talks, he goes through this cognitive, behavioral, emotional, and physiological list, and the need to think about executive function, which overlaps a lot with self-regulation. Executive function, I've only mentioned briefly. This is, again, a very quick riff through executive function. It covers things like activation, organizing and prioritizing what you do, initiating what you do and getting started, focus, attention especially, sustaining your attention, shifting your attention, and completing activities and knowing that you've completed them. Effort, regulating your alertness, not burning up, not using all your energy too quickly and burning up, but also not using so little energy that everything falls apart and fails. Then emotion, managing your frustrations, modulating your emotions, and keeping a good, healthy, realistic emotional perspective, which can be very difficult for this population of children. Memory, is an important part of executive function. Remembering things, accessing recall so that you are able to use the remembering, recognizing things and remembering initially sequences and then longer term things. And finally, actions, monitoring and regulating your self actions without being too impulsive, without using the wrong contexts, or without using the wrong pacing. And Hartshorne and Nicholas actually make a point that they think that executive functioning probably includes self-regulation. Self-regulation would be a part of executive function. This is the introductory article that looks at self-regulation right across the board. And then the articles go into these separate items. I've talked about arousal levels, and here's just one example. At the top, you've got the highest level of arousal, and at the bottom, you've got the lowest level of arousal. And I think of this as I call it the ladder of arousal. And I think of it as a ladder we're all on, and we move up and down the ladder. And sometimes we move up and down the ladder by outside events, by what's happening around us and the context we're in. But we also move up and down the ladder by internal events like hunger, indigestion, pain, fatigue. And we also, which is very nice, as our self-regulation abilities develop, we can also move ourselves up and down the ladder quite consciously in a planned way. And that's what I was doing at 2:30. I'd gone down the ladder quite a bit. And to be honest, I was at the drowsy level. And I would normally have probably had a nap, but I knew this webinar was coming up. So I did a few things that got me to the active awake level. And then, because I'm a fairly nervy, high arousal person, my body moved up to fussy awake. And I became a little bit hyper, because that's where I work best, especially when I have to present for 2 hours and I need to maintain focus and pace myself so that my energy doesn't run out. Now, the children in the population with deafblindness and complex multiple disability don't know about this ladder, and they probably don't know where they are on the ladder. They probably don't feel these states the way that we do, and they probably don't have language to identify the level they're on. So we may have to work with them on that. And I think there are many ways this can be done. I was going to say a lot, but like the challenge when working with a child on awareness of arousal levels, first of all, where are you on the ladder is a tough one, but we need to think about that. Where do you need to be? So if you're not in the most appropriate place for where you are or who you're with or what you're doing or what you're expected to be doing, where do you need to be and how can you get there from where you are? And the ladder can be used in all sorts of ways. The one I showed you has 9 steps. You could use far fewer steps. And I've seen just 2 steps, almost like good and bad, happy, unhappy, feeling good and feeling tired. You could then build to 3 steps, and the number of steps on the ladder could increase as the child's understanding develops. You could use a very individualized vocabulary. You could use written words like the slide I showed you. You could use symbols. You could use pictures of faces. You could have smiley faces and frowny faces and crying faces. You could have brailled words. It's entirely, individualized for the student. You could do revisiting or reflecting or social stories. Revisiting means after there's been a meltdown, after perhaps there's been a tantrum, depending on, I think of a meltdown as being involuntary, a tantrum as being something a little more controlled in the child. At an appropriate time, suggesting to the child that you go back to it. And of course, this depends on a certain level of communication and language ability. And the classic line that I use, and it usually gets a laugh, is when you say to a child, "So why did you bite Mary?" Or, "Can you remember why you bit Mary this morning?" And seeing if they're able to go back and think about what happened. And social stories give you the advantage, of course, of taking the spotlight off the child. And in my experience, children with deafblindness are often particularly interested in social stories where a child gets into trouble. They seem to have an innate attraction to somebody else being in trouble, doing something bad, and being told off. Role play could be a possible strategy. And also, what do you like? What do you need? So we need to improve our reading of the children. We need to make connections between their behavior and what led them to this place. We need to help the children feel their bodies more effectively. We need to provide an increasingly precise vocabulary of emotions or emotional states. We may need to direct the child's attention to the fact they seem to be getting stressed or they seem to be getting tired or whatever. We may need to remind them of strategies, as in, are you getting a bit tired? What do you need to do, or what would you like to do? And it's quite helpful to match or share experiences and feelings about when another child felt the same way, or when I felt tired, or when I got frightened, or when I got angry. And here's an example of the ladder from a real life example that a parent made. It's a British parent, so the language is very British. At the top, you've got happy, and then calm, and then quiet, and then whiny, and at the bottom, cross, which means angry. It's very British. And they've even got a sun at the top. It's like a weather chart. And you've got rain clouds and a lightning bolt at the bottom. And you've got the black arrow, and the child is encouraged to move the arrow up and down to show how they're feeling about things. And I've seen this used very effectively with children who really like the idea that they are able to indicate when they're getting tired, when they're getting bored, when they're getting fed up, in a way that seems to be approved of by the authorities. And I've seen this used in all sorts of different ways. Now on to sensory integration very quickly. Jean Ayres was an occupational therapist, as I said. She described a neurological process that we need to go through, which she called sensory integration. She developed a theory about it, and then on the basis of that, she came up with a therapy approach that's called sensory integration therapy. And although she died a long time ago, sensory integration therapy is now widely used all around the world. It's very much an occupational therapy field. And this is one of the ways she defined sensory integration: the neurological process that organizes sensation from one's own body and from the environment, and makes it possible to use the body effectively within the environment. The spatial and temporal aspects of inputs from different sensory modalities are interpreted, associated, and unified. Sensory integration is information processing. The brain must select, enhance, inhibit, compare, and associate the sensory information in a flexible, constantly changing pattern. In other words, the brain must integrate it. And I talked about this at the beginning of this session when I talked about the way that the senses develop and that the brain needs to acquire skills in picking out certain sensory inputs, emphasizing those and attending to them, inhibiting or ignoring the others, comparing and associating them and interpreting them, and then making decisions. This is good, that's bad. I want more of this, I want less of this. I'm going to go closer and get more of that. I'm going to move away and avoid that, and so on. When she was asked about the key principles, she said there were 4 basic key principles to the therapy: the just right challenge, the adaptive response, active engagement, child-directed. And as I've already said, Jean Ayres believed very passionately that this was child-directed therapy in the sense that the therapist observes the child to see what kind of sensory inputs are they seeking and what sensory inputs do they seem to be avoiding. And on the basis of that, they come up with a therapy program that involves a range of things that might be movement activities. It might be manipulation of the child's limbs to use rhythmic joint compression and stretching. There might be a brushing protocol, which I talked about 2 weeks ago, with a specific brush used in a way specified by the therapist, and so on. The just right challenge is a lovely concept. And what that means is the child has to meet challenges because that's their learning point. For me as a teacher, that would be my teaching point. But I have to know the child in order to know that they'll be able to be successful. That's what makes it just right. And the challenge provokes an adaptive response from the child, number 2. And that's where the child is starting to integrate their sensory systems more effectively. For me, that's where the child is starting to learn and extend their skills. The child has to be actively involved. So you don't do this to a child, you do it with the child, like good teaching. And it's child-directed in that the child shows you their motivators and the child shows you what they need. And of course, where an OT would see a child self-stimming and would learn from that what kind of sensory diet the child is giving themselves, and they would base their therapy program on that. In the deaf-blind field, we might follow Van Dyke's idea that if a child is self-stimming, say rocking side to side, maybe we could lay on the floor next to them and we could rock side to side. We could join them in their self-stimulation and start to build a relationship. Start to show the child that we can do what they're doing. If they're flapping their hand and looking at the light and making interesting shadows, are we able to flap our hand and maybe even offer them our hand to use instead of their own? And Van Dyke makes the point that joining the child in their self-stimulation behaviors can be the most effective way to start to build a relationship and move into effective teaching with them. Sensory integration dysfunction. Linda Stevens suggests that the way this demonstrates itself, you see problems with attention and self-regulation, you see sensory defensiveness, you see activity levels like being very disorganized, very immobile, lots of repetitive or stereotypical behaviors. The child might be very clumsy, might be overexcitable, or might be looking for very strong sensory inputs. And there is a whole range of possible challenging behaviors, all of which indicate that there's a need for sensory integration support. And Karen Nagel suggests that the main aims of sensory integration therapy are to achieve an alert, calm state, self-regulation, to promote the organization of the central nervous system, to enhance the child's ability to regulate and adjust the sensations from their environment, and to increase conceptual development. Very much like a list I could write about my goals in teaching a child with complex multiple disability. I talked last week about my assessment questions, and again, you can see the connections here with everything I've been saying today, and with Jean Eyre's list, and with the things that Jude Nicholas and Tim Hartshorne are promoting. I want to know how the child feels. I want to know what they like. I want to know what they want and how they demonstrate it. And I'm especially interested in what they do, because that gives me insight into what they need. If they self-stimulate, it's perfect for me because they're feeding me information. I'm going to skip. I was going to talk about self-determination and sensory inputs, but I'm going to go right to the end, my last two slides, because we only have 4 minutes left. Things to remember. Behavior offers you a message, so it can be regarded as a form of communication if you want it to be. You've got to be open to this. And believe me, it's really helpful to accept the child's communication as a behavior, as a communication. They might not be intentionally communicating, but it really sends messages to you if you're interested and if you're focusing on it. Children with complex multiple disability may have great difficulty with their ability to self-regulate, and their behavior may be their attempt to manage. And as I've said, from the womb, children self-stimulate in order to self-regulate. But our population may well have been denied that in the womb, because if they have congenital abilities that were present in the fetus, that may well have put a barrier up to those things developing. Multiple disability and sensory integration problems can significantly impact the child's ability to self-regulate. Do not attempt to change a child's behavior until you understand what it means and why the child is engaging in it, unless it is dangerous or illegal. And I always have to put that rider in. Do not try to eliminate a behavior until you have something to replace it with that will serve the same function. And you can only have something to replace it with if you've bothered to interpret the original behavior and get to know the child and get to know their motivators. Try to make sure that the child knows that you know what they are communicating. In other words, the importance for the child of being understood and knowing that they're understood. And finally, always respect communication. Now, I know even more than my first two webinars, this was a kind of overload of information. I've only done it this way, partly because all these things are important and relevant, but also because I know this is being recorded, so it would be possible to watch and listen at a speed that's more acceptable to learning, and it's possible to revisit and go back again and again. And as I said right at the beginning, if I haven't given you any precise, clear, concrete strategies, which wasn't my goal, I hope I've given you perhaps a different lens through which you can look at the children, or a different set of expectations that you can bring to your work with the child that might make your input and your teaching more effective. And I hope above all else that I've stimulated you to go further in your reading and your investigations.